So my name is Animesh Ray, and this is what I'm going to talk about over the next 20-25 minutes. The current scenario of Aspergillosis in India. I do not have any specific conflict of interest regarding to this talk. Now, I'm sure most of you must have heard about New Delhi and India, but just to ensure that everybody is in the same page. So I come from the capital of India, which is a country in South Asia. I live in New Delhi. New Delhi is actually a very large city. It consists of around 27 million people. A lot of people in a city the size of London, I'm told. And it has got a lot of lovely places. We have got obviously our own set of problems, overcrowding being one of them. But we also have a lot of good monuments where we get a lot of footfalls. And talking about footfalls, we also get a lot of footfalls in the institute where I work at, that is All India Institute of Medical Sciences, New Delhi. So this is my institute, and this is what I do. So I'm an internist, pulmonologist by training. So I get to see a lot of patients with chest diseases, both in my clinic and in my inpatient services, where I get to see a lot of patients having aspergillosis. So that's what I'm going to talk about, my or our experience with aspergillosis and how India is faring as far as aspergillosis is concerned. So this is loosely the subtopics which I'm going to talk about, the different form of aspergillosis, just the basic things regarding that, how frequent it is, the symptoms, diagnosis, and treatment, and finally, how is the scenario unique in India. Now, this has already been alluded to. So we know that it's a fungal disease, that is aspergillosis. It can affect different parts of the human body, but most commonly it involves lungs, and I get to see a lot of pulmonary aspergillosis. Now, what is interesting to note that there might be varied manifestations due to aspergillosis. Even if when we talk about pulmonary aspergillosis, it has got different forms. So it may be either acute, allergic, or chronic. So acute is something which I get to see in the wards or in the intensive care units where patients are more sick. Allergic is usually patients present with asthma-like symptoms, and chronic is usually patients who present to the clinic with chronic symptoms. They usually have a history of a prior lung disease, and on top of that, they get fever and other problems. So that is chronic pulmonary aspergillosis. Now, IPA, as I said, it happens in usually sick patients. Usually the patients are immunosuppressed. So in our country, usually we get in patients who are having, say, malignancies, hematological malignancies like leukemia, lymphoma. Also in patients who may be critically ill, who are poorly controlled diabetes. Diabetes is very frequent in India, or patients who are on steroids for different reasons for a long duration. So they might present with a constellation of symptoms: fever, chest pain, breathlessness. What is interesting about IPA is that the diagnosis is not simple. The diagnosis is often by a combination of clinical hunches, of imaging, X-ray, CT scans, and ancillary diagnostic modalities like microbiology, like growing aspergillus in a culture or some biomarkers in the blood and so on. The treatment almost always is parenteral antifungals, that is intravenous antifungals to start with, before we switch to oral antifungals once the patient becomes stable. Now, allergic bronchopulmonary aspergillosis, it's a totally, a different cohort of patients. Most of these patients, they have asthma or cystic fibrosis. Now, cystic fibrosis as a disease is not common in India. My pediatric colleagues get to see some patients, but as a disease, it's very infrequent in India. So most of our patients, they have asthma. These patients, they behave like asthmatics. That is, they have cough and breathlessness, which runs throughout the year with exacerbations. And only when often their symptoms do not respond satisfactorily to inhalers, that allergic bronchopulmonary aspergillosis or ABP is suspected. Usually a number of blood tests and imaging features they are run, and a diagnosis of ABP is made. Now, treatment is usually with the help of anti-inflammatory steroids, and in some cases, antifungals are used. Finally, about chronic pulmonary aspergillosis. Now, they occur in patients with the prior respiratory conditions, as I was talking about previously. Now here in India, and I'm going to talk about it later, we get to see a lot of patients of CPA or chronic pulmonary aspergillosis in patients who have had prior history of tuberculosis. We get some amount of COPD patients. Now, in the Western literature from the Western countries, like say UK, we see that more number of COPD patients, they have chronic pulmonary aspergillosis rather than post-TB sequelae, because tuberculosis is much less common, say, in United Kingdom than in India. Now, these patients, they often have features, symptoms for a long time, say typically months to years, fever, weight loss, hemoptysis, and most of the time they are treated by physicians symptomatically by some antipyretics or by some blood stopping agents. It is only when they have blood tests and they have some scans like CT scans that reveals telltale features. Like, for example, in the CT scan, you can see a big ball-like structure sitting, which is suggestive of an aspergilloma and the diagnosis of chronic pulmonary aspergillosis. Treatment, again, is usually with oral antifungals, and it has to be given for a long duration, typically 6 months. In some cases, it is extended. In some cases, it is lifelong. So how frequently are the different conditions in India? So recently we addressed this in one of our studies done together with Dr. David Denning, and this was the details of the study received a lot of attention and traction. This was reported in a number of newspapers around India, and it was reported that around 57 million people of Indians, they are affected by one or more serious fungal diseases. So if we look at this, out of total 1.4 billion people, around 4%, that is 57 million people, have serious fungal infections. Out of them, aspergillosis, if we look at the numbers, they are also pretty huge. Invasive pulmonary aspergillosis, almost 250,000, but then again, the caveat is this is only in some select group of patients having something called the COPD, lung carcinoma, leukemia, lymphoma, that is hematological malignancy, or HIV. For ABP or bronchopulmonary aspergillosis, the numbers are much more, 2 million, and for CPA, it is close to 2 million, a little under it. So if we compare these numbers, I try to compare this with the existing literature, and most of these data, they are taken from the different studies done by Gaffey. So at different time points, so India, we did it in 2022, the rest of it 2020, United Kingdom 2017, and the global data was out in 2017. So they may not be comparable, but just to get an idea that invasive pulmonary aspergillosis, out of a total of 1 million, which was reported in 2017, China has more amount of invasive pulmonary aspergillosis cases as compared to India. But when you look at EBP and CPA, the numbers are much more. So India has close to 2 million people of EBPs, and for out of a total 5 million. And for CPA, it is around 1.74 million out of a total of 3 million. So we do have a lot of cases of allergic bronchopulmonary aspergillosis and chronic pulmonary aspergillosis in India. Not only because we're a big country, but also probably because of our unique features, unique demographic features, as well as the fact that our population has got a higher frequency, higher incidence of tuberculosis and other factors. So how is the aspergillosis scenario unique in India? I'm going to talk about the different factors. One is obviously the different population. As I said, say any study from UK, they would usually report 1/3 of their CPA occurring in COPD patients. But in India, almost 90%, more than that actually, they occur in post-TB patients. What is interesting also to note is that a lot of these CPA cases, they're seen in patients belonging to the lower socioeconomic stratum. The one reason being tuberculosis. We have around 2 million cases of tuberculosis every year in India. A lot of them occur in poorer section of the society. Now, when they recover, they have structural lung disease, and these structural lung disease predispose them to the development of chronic pulmonary aspergillosis. So CPA in turn also develop in this group of patients who are financially underprivileged. Similarly, ABPA not only in asthmatics, it can also occur in post-TB patients. I already said that cystic fibrosis as a predisposing factor for ABPA is not so common in India. The number of invasive pulmonary aspergillosis, it is also increasing. That is because that, with the enhancement of the ICU facilities and the increase in the number of the transplant services and bringing up of more hematological centers, we are getting more and more patients who are acutely ill with invasive pulmonary aspergillosis. Now, CPA and tuberculosis, I think this might be a question which might be running through the minds of some viewers. How are they related? Well, the relationship is actually complicated. So you imagine a patient who's coming to me with complaints of, say, cough and fever for a few months, and I get a CT scan done, and I see that you can make out some cavity-like structures in the X-ray. So I run some tests for him, and if they are positive for tuberculosis, it's fine. But say in at least 50 to 60% of the cases, they might not be positive for any particular organism, not for tuberculosis, that is. So in that case, we have to think about the other possible causes. So one such cause is chronic pulmonary aspergillosis. So that is because if we see the clinical features of CPA and TB, they are more or less same. So this Venn diagram represents that. So fever, night sweat, as well as cough, weight loss, fatigue, breathlessness, these all might be seen in both the group. Some of the symptoms may be more common in one group than the other, but in the clinical practice, it's very difficult clinically to differentiate between tuberculosis and chronic pulmonary aspergillosis. So in 15% of patients who are presumed to have tuberculosis, they might be having chronic pulmonary aspergillosis. So that is the confusion part. Secondly, what might happen is that both of them, chronic pulmonary aspergillosis as well as tuberculosis, might coexist. So the patient had tuberculosis, had a cavity, and then cavity got colonized by Aspergillus, and they subsequently had a disease. So they both have, they have both chronic pulmonary aspergillosis and tuberculosis. So this might happen in 5% of the cases of newly diagnosed pulmonary tuberculosis. Aspergillosis might develop during treatment of the patient. So the patient says they are on anti-tubercular therapy, but their cavities are there. The tuberculosis is getting the tuberculosis is getting resolved, but the cavities, they are being colonized by Aspergillus. And these patients, by the time they complete their anti-tubercular therapy, which is usually around 6 months, they might develop chronic pulmonary aspergillosis. So this happens in around 10% of the cases. And even if they are not developing chronic pulmonary aspergillosis by the end of the treatment, they might develop the same in the subsequent years. So this is what we call as compounding. So the risk may differ based on whether they have a cavity or they do not have a cavity. If they have a cavity, the risk is much more. So it is 6.5% annually. If they do not have a cavity, the risk is much less. But if you consider the huge number, you can realize that a lot of these patients with post-tubercular sequelae, the past history of tuberculosis, they ultimately develop this condition of chronic pulmonary aspergillosis. So, just to give you an example of a patient, how we are treating these patients in our hospital. So this patient, Mr. J, he was a 55-year-old plumber. He actually traveled to New Delhi from a neighboring state. I mean, not a neighboring state, from a faraway state, which is around 1,000 kilometers from AIIMS, New Delhi. So he was under a follow-up for the last 2 years where chronic pulmonary aspergillosis was picked up. He had tuberculosis around 10 years back. After that, he had been having cough and sputum, which increased for around 2 years before he came to our center. And he was ultimately shown to have features of chronic pulmonary aspergillosis, started on treatment, and he did pretty well. But then recently he had a worsening. He had very high grade fever with increased cough and sputum, purulent sputum, that is. And so he was diagnosed with a patch in the lung, or what we call pneumonia. He was admitted, was on oxygen therapy. He subsequently responded to therapy and was recently discharged. Right. So talking about aspergillosis, aspergillosis we are seeing not only in the perspective, in the background of tuberculosis or acutely ill patients or asthma, but the recent COVID-19 pandemic also surprised us with some new features of aspergillosis. One is the CAPA, or the COVID-associated pulmonary aspergillosis. This was not from our center, but from a center in North India, which which reported a lot of patients having COVID-19 associated pulmonary aspergillosis, which was essentially a form of invasive pulmonary aspergillosis developing in patients having severe COVID-19. We also reported aspergillosis, not acute aspergillosis, but subacute invasive pulmonary aspergillosis in around 10 patients from the severe COVID-19 cohort admitted in our hospital at our COVID-19 center. Most of these patients, they had diabetes. Most of these patients, they were on steroids for a long duration. So these conditions made them susceptible to um, pulmonary aspergillosis, and they presented with a history, not as acute as invasive pulmonary aspergillosis, but a more long drawn history suggestive of subacute invasive pulmonary aspergillosis. So again, the question, I think a lot of you might have heard about the black fungus epidemic in India, which kind of was reported all over the world, and it attracted a lot of attention and a lot of research into this. But similarly with black fungus epidemic, we also had something called the green fungus epidemic, where aspergillosis, as in CAPA or in subacute invasive pulmonary aspergillosis, they also were seen in increased numbers during the COVID-19 pandemic. So the possible reasons for aspergillosis, we are not sure. We have been doing some research on that, and what we can infer from the other researches that we have done on other fungal diseases associated with coronavirus is that most of these patients, they were sick. So if you're sick, you're more predisposed to develop aspergillosis. Most of them had immunosuppressing agents like steroids going on for a long time. They had diabetes, again, which compromises your immunity. And as it was suggested in this particular article, which was about mucormycosis, the prolonged use of masks unhygienically might have also been a putative factor. Now, these patients of chronic pulmonary aspergillosis, obviously they have symptoms, but they also have poor quality of life. We reported the quality of life in a cohort of post-tuberculous E. coli patients, including chronic pulmonary aspergillosis. And what we noticed was that the SGRQ, the St. George's Respiratory Questionnaire, which takes into account some features like the symptoms of the patient, the activity limitation, and the impact of the disease. It has the impact of the disease on the patient's life. And what we noticed was that these patients, they fared much worse as compared to the other patients presenting to the chest clinic. So coming back to how this scenario of aspergillosis is unique in India. So I talked about the population. Next is obviously about the diagnostic capacities. One is there is no dedicated program, unlike tuberculosis in India, to look at CPA, though we have a lot of patients of chronic pulmonary aspergillosis. Some diagnostic modalities like serological tests like IgG aspergillus, which is used to diagnose chronic pulmonary aspergillosis, they might not be available at all parts of India. And even if they are, they might not be affordable to all those patients who have to pay out of their pocket. Some diagnostic tests, like we recently did a study on a point of care test, which had shown some promising results in Western studies, in Western population. But in our study, the results were somewhat promising, but not as promising as that seen in the studies from outside India. So this kind of reflected the fact that we need more tests which are affordable and more tests which can be done point of care and more and tailored more to our population for picking up more and more cases of chronic pulmonary aspergillosis. Now, talking about the labs, I know this is a busy slide, but all I needed to understand that the mycological capacity of our country. So this is India. This was a survey from 7 Asian countries: China, India, Indonesia, Philippines, Singapore, Taiwan, and Thailand. This was done in 2018, and it looked at the different laboratories from India. Around 104 laboratories they were surveyed, and they looked at the different factors, including staff training, the quality control, and whether the safety measures they were in place. So India did not do. India did. The performances were comparable with that of other countries in most of the parameters. But what needs to be understood is that 104 mycological laboratories for a country of 1.4 billion is again too less. So we need more laboratories who would be able to run all the mycological tests, to diagnose chronic pulmonary aspergillosis. Similarly, therapeutically, the availability of antifungals sometimes is an issue. So we have something called the National Essential Drug List, where itraconazole, amphotericin B, they are within that. So they are freely available in most of the government hospitals around the country. But some drugs like voriconazole, some drugs like liposol amphotericin B, they may not be available in different parts of the India. Also, we have a very strong private hospital setup, at least in the urban area. Now, the practices of the urban medical setup might differ from that of the government hospital. So, in some cases, it has been seen that the private hospitals, they might have a tendency for early use of antifungals, while the government hospitals, they might have, the tendency for for having a more cautious approach. So overuse or underuse, they seem to be a problem in our country, and we needed a uniform policy for as far as treatment with antifungals is concerned. Talking about treatment, so we try to tinker with the available treatment. So injectable amphotericin B, it is something which is used intravenously. So we try to see whether this can be used in a nebulized manner for patients of chronic pulmonary aspergillosis. So some data is already there regarding treatment of some treatment of prophylaxis of certain conditions of aspergillosis, like invasive pulmonary aspergillosis with nebulized amphotericin B. So we did a very small study, and the preliminary results look good. But then again, these are very early preliminary data, and we need to replicate this in a larger study before which we can put them to use. Again, coming back to the question how the scenario is unique in India, talking about the fungus, also the fungus population may be different in India as compared to the countries outside India. One common thing that we see is that Aspergillus flavus, they are more common from all the studies reported from India as far as chronic pulmonary aspergillus is concerned. So around 1/3 of our patients, 20 to 30% of our patients might have Aspergillus flavus. The most common being again Aspergillus fumigatus, but this is something which is which is different from the other studies. Also, our population, a lot of our population is involved in farming activities. So as Aspergillus is only present in the environment, so farming activities and other similar activities, they make them these people, they have a higher chance of exposure and more chance of development of this disease. Now, finally, talking about the research in India, I tried to just compare the world data and Indian data over the years. So you can see that overall, globally, the interest on Aspergillus seems to be having an upward trend, which is good. In India also, except for the lull during the COVID-19, there is an ascent of the curve, which is again looks very promising. But again, we feel that we need to have more and more research into the different aspects of aspergillosis to treat this such a huge load of aspergillosis patients in our country. So this is how I'm going to end. So I would like to sum it up by saying India obviously has a very high burden of aspergillosis. Not only a unique population, but there is also a set of challenges, diagnostic, therapeutic, and otherwise. And the focus should be on more amount of research and modernization. Now, I would like to end with this. I think there was a question in the chat box also about kakapodes. So, interesting story about kakapodes. Kakapodes, for those who are not aware, they are called owl parrots. They are the largest parrots. They are only flightless parrots, which are commonly found not in India but in some islands off the shore of New Zealand. A couple of islands, they are endangered. Around 200 to 250 odd adult kakapodes there. In 2019, there was an epidemic of aspergillosis, and which threatened to wipe out this whole population. So what the New Zealand government did with other NGOs was to airlift a lot of these kakapodes to the surrounding veterinary hospitals, have advanced imaging on them, and treat them with antifungals. And with that, the fatalities due to the epidemic of aspergillosis could be minimized. So I think what this story reflects, what this incident, rather two incidents reflects, is that aspergillosis A can be a killer of a disease, and B, we can make a difference if we put a mind to it. So I would like to end with that. Thank you.
Thanks, Animesh. We've got a couple of more questions in the chat, if that's okay. We've got a question from Kwate, who asks, is there any experience in India with invasive aspergillosis point of care testing?
So there is some data regarding invasive aspergillus point of care test, but we are not we are doing some studies regarding the point of care test, but till now it has not been standard of care. It has not been kind of validated in our population yet.
That's brilliant, thank you. And then we've got one more, which is, can Aspergillus nigilans cause IPA?
So it's not a common species, so I need to look this up. I'm not sure whether this causes invasive pulmonary aspergillosis.
That's great. Thank you, Animesh. What we can do is any questions like that can't be answered, we can put together a Q&A afterwards and we'll email it out to all the participants. Thanks, Animesh.
Animesh, I have a question if nobody else has. I think you touched on it a little bit earlier. In temperate regions like the UK, we're being told that global warming is warming our environment, and this may increase the threat to our health of infection by fungi like Aspergillus as they evolve to live in warmer temperatures. Well, India already has warm temperatures. Do you think that that's already a factor in the evolution of Aspergillus infections in India?
Yeah, sure. That's a great question, Dr. Graham. Thank you for that. So I actually believe that may be one of the reasons why we are seeing more and more number of cases globally.
Yeah.
So probably global warming is contributing to that. Aspergillosis as a case, I think, as disease is seen more commonly in countries with hot and humid climate. So probably global warming is adding to that. I think that's very pertinent.
Thank you. Any more questions?
We've got no more questions in the chat.
Okay, well, that just reminds me to thank Animesh. That was an excellent talk. Very interesting to hear about what goes on in a huge country with a completely different health system.